Good morning, everyone. I'm Dr. DARSHIL SHAH, and so I'll just begin with my case. So our patient is a 78-year-old retired male. He's right-hand dominant. He presented to another local orthopedic surgeon with complaints of right shoulder pain and inability to move the limb. He says that he had those symptoms after returning from the gym. He doesn't give any history of fall, trauma, or doesn't give any history of epilepsy. The other orthopedic surgeon diagnosed him to have an acute episode of posterior shoulder dislocation, and he underwent close reduction under general anesthesia within 24 hours. Following the reduction, an abduction brace was applied for the patient. Though a check X-ray is unavailable, the operative notes do say that the humeral head was confirmed to be reduced on the C-arm image. So the patient then followed up with a primary surgeon himself, where another X-ray was taken, but it was diagnosed to be re-dislocated. The patient was offered a treatment option, but then the patient chose to neglect his symptoms. And then he presented to us at 3 weeks mark, basically 3 weeks from the time he had a second episode of dislocation. So he presented with the similar complaints of pain and inability to move the limb. On examination, he had restricted active and passive range of motion. Neurological examination was normal. The MRI shoulder showed no relevant associated pathologies, and EEG and neurology testing otherwise was normal. So this was the X-ray presentation at 3 weeks, where we can see a reverse Hill-Sachs defect and something out here which we presume to be a glenoid rim fracture, which was confirmed on CT scan. So this was a 3D CT scan of showing the reverse Hill-Sachs and a locked posterior shoulder dislocation. So on this card we can see that probably the inferior glenoid rim was fractured, and there's a large reverse Hill-Sachs defect that we see, and which is analog posterior humeral head dislocation.
So what went wrong, Darshil, with the first management?
So actually the history is quite vague for the patient, because he says he doesn't give any relevant history of trauma, fall or anything. He said he was in an abduction brace, because I suspected he probably removed the abduction brace. That's why he re-dislocated it. But he says he was very compliant, and when he just went for a regular follow-up, and when it
What went wrong?
SHAH, okay. History, correct, yes, sir. So I think that close reduction, something more should have been done in the index at the
simple things.
Yes, sir.
Firstly, I mean, he must be extremely osteoporotic to go in the gym. The rim fracture happened first, otherwise it's inconceivable that a shoulder can dislocate posteriorly. It's so rare to dislocate posteriorly. The whole biomechanics of a shoulder is conspired to dislocate anteriorly. So why is it? Abduction brace was ensuring that he will re-dislocate again.
Right.
He should have put him in a external rotation brace.
External rotation brace, okay.
By doing abduction, you are encouraging internal rotation.
Internal rotation, right.
You see?
Correct.
So that was a disaster. Even if you had put him in, kept him down without a sling,
right.
The sling is encouraging internal rotation. Internal rotation is a feature that is going to encourage dislocation.
Yes, yes.
They need an external rotation brace. He would have settled down, he would have healed up.
Fine. Fine. So he presented to us at 3 weeks, and after 1 week, after counseling him, he came back after a week, and that's when we did an open modified McLaughlin procedure. Unfortunately, I lost the intraoperative images, so I tried to make an illustration of what we did. So we put two medial row anchors here and passed them through the subscapularis, and we created a tunnel here, transosseous tunnel, and used a lateral row anchor to affix this fragment out here. So this is
no screws?
Sorry, sir?
Screws?
Why not screws?
Why no screws? Yes, sir. So that's what my other ARS was. That I just preferred to. The fragment that I obtained was not very big, and I thought in an osteoporotic bone this may be more reliable for me and may not crush the fragment. So I preferred doing.
Can I do the osteotomy after cutting the subscap or before?
So before, as in I did the osteotomy along with the subscapularis that was attached.
Can I just ask what's the fragment on the glenoid side?
So glenoid, so that's what we, on the CT scan, if you see, it was an inferior glenoid rim fragment that we suspected it to be there out here.
Okay. That nothing was done to that.
So nothing was done, it was left alone.
So you don't have a 3D of the glenoid?
No, sir. 3D of the glenoid was
What
done.
you see on an X-ray and what you see on a sagittal reconstruct 3D
Okay, sir.
is chalk and cheese.
Okay.
Once you do a 3D sagittal, you will see it's a very big fragment.
You also have the, he also has the axial cuts. Can you go back to the CT?
Yeah, but the 2D is underwhelming. The 3D sagittal reconstruction will show you a far bigger fragment.
Far bigger, perhaps second.
So do you think that that glenoid fragment was adding to the instability? Ashish?
Yeah. But that was the root cause. Without the glenoid fracturing, the head was not going to go behind.
So then we put him in a gun slinger splint for 4 weeks. And post-operatively, so this was something where it was interesting that 6 months post-operatively gives a history, his relative gives a history that the patient did have a seizure in front of him after that. We repeated the neurological examination, we did an MRI brain EEG, but everything was still normal. So the neurologist diagnosed him to have a degenerative brain disease which gave rise to those dislocations. One good thing that he did not redislocate following that episode of seizure. 8 months following the surgery, he had a stable shoulder, as in with no redislocation. He did complain of some amount of pain. Active forward elevation was about 100 degrees, external rotation was about 60, and internal rotation as demonstrated.
So can you go back to the previous X-ray?
This one?
Yeah.
All right, yes.
So I think he's developing a bit of
A little bit of
Arthritis.
osteoarthritis, yes.
that will
yes.
make him more stable,
Correct, yes,
though
sir.
a bit painful.
Why would you have arthritis?
Probably secondary to the modified McLaughlin that was supposed, and along with the inferior glenoid rim fracture that may have contributed to it, sir, possibly.
So because the
It
head
was
is
a
not
non-anatomic,
centered.
sir.
The head is not centered.
That is not centered.
And you've tightened him anteriorly.
Correct.
So there's an obligate
Posterior
posterior
subluxation.
subluxation. So it's off center. And
Correct.
then so there's a point loading.
Correct, sir. Got it. Just showing active forward elevation and internal rotation. And this is the external rotation that we observed at 8 months. So yeah, so the take-home messages is that luckily for this patient, he was diagnosed initially to have a posterior shoulder dislocation, but up to 80% of the cases are missed. But as Dr. Babulkar sir correctly pointed out, maybe if he would have given he would have had an external rotation brace at the first episode, he may have not had this cascade of events that followed. So things to look out for is the triple E syndrome that we commonly know as elderly epilepsy and electric shock. One thing that I kind of realized with this is convulsions in old age may not manifest in neurological tests. Modified McLaughlin is a reliable procedure in the elderly population. While doing my review of literature, kind of following the case, I came across an article which says tramadol overdose can cause convulsions. Obviously, this is more over a period of a year or two. And because tramadol is available like as an over-the-counter medicine in our country, it's probably more likely, though I have not heard of anyone having that till date. Obviously, it is always necessary to obtain a check X-ray, and CT scan is a must in suspected cases of posterior shoulder dislocation. Thank you, sir.